Hello, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 61, Drugs for Allergic Rhinitis, Cough and Colds. My pages, as always, may not line up perfectly with your own, but we'll be reading the chapter in its entirety. The drugs addressed in this chapter are given to alleviate symptoms of the common upper respiratory disorder. Our principal focus is on the symptoms of allergic rhinitis and the common cold. So, drugs for allergic rhinitis. Allergic rhinitis is an inflammatory disorder that affects the upper airway. Major symptoms are sneezing, rhinorrhea, pruritus, and nasal congestion caused by the dilation and increased permeability of nasal blood vessels. In addition, some patients experience associated conjunctivitis, sinusitis, and even asthma. Symptoms are triggered by airborne allergens, which bind to the immunoglobulin E, also known as IgE, antibodies on mast cells, and thereby cause release of inflammatory mediators, including histamine, leukotrienes, and prostaglandins. Allergic rhinitis is the most common allergic disorder, affecting almost 1 out of every 6 people living in the United States. Allergic rhinitis has two major forms, the seasonal and the perennial. Seasonal rhinitis, also known as hay fever, occurs in the spring and fall in reaction to outdoor allergens such as fungi and pollen from the weeds, grasses, and trees. Perennial or non-seasonal rhinitis is triggered by indoor allergens, especially house dust mite and pet dander. Several classes of drugs are used for allergic rhinitis. So we'll look at that table 61.1. Principles among these are the glucocorticoids or intranasal, antihistamines, both oral and intranasal, and the sympathomimetics, oral and intranasal. So we'll do a quick overview here of some of the drugs for allergic rhinitis. Your glucocorticoids, the nasal route, prevent the inflammatory response to allergens and thereby reduce all symptoms. Some of the adverse effects include nasal irritation, possible slowing of linear growth in children. Antihistamines, both oral and nasal, block histamine 1 receptors and thereby decrease itching, sneezing, and rhinorrhea. They do not, however, reduce congestion. So, adverse effects for oral include the sedation and anticholinergic effects, where nasal might give you a bitter taste. Cromolyn, a nasal spray, prevents release of inflammatory mediators from mast cells and thereby can decrease all symptoms. However, benefits are modest. There's no known adverse reactions or effects. Sympathomimetics, both oral and nasal, activate the vascular alpha 1 receptors and thereby cause vasoconstriction, which reduces nasal congestion. Do not decrease sneezing, itching, or rhinorrhea. The oral route can cause restlessness, insomnia, and an increase in your blood pressure. The nasal can produce a rebound nasal congestion. Anticholinergics via the nasal route can block nasal cholinergic receptors and thereby reduce secretions. They do not decrease sneezing, nasal congestion, or a postnasal drip. The adverse effect, for obvious reasons, then would be nasal drying and potential irritation. Your anti-leukotrienes, the oral route, block leukotriene receptors and thereby reduce nasal congestion. A rare adverse effect would be the neuropsychiatric effects. So, looking at the overview of drugs for allergic rhinitis, approaches to rhinitis management are based in large part on the diagnosis and management of rhinitis. An updated practice parameter from 2008, an evidence-based guideline developed by the Joint Task Force on Practice Parameters, representing the American Academy of Allergy Asthma and Immunology. The American College of Allergy, Asthma and Immunology, and the Joint Council of Allergy, Asthma and Immunology. The American Academy of Otolaryngology Clinical Practice Guideline Allergic Rhinitis 2015 provides a further guideline and guidance by individualizing drug choices for symptom control. An algorithm for the management of allergic rhinitis developed by the AAO is shown here in that figure 6D1.1. So here you're taking a look at some of the pictures here. The nasal congestion is a dominant complaint. So you can have the intranasal glucocorticoids and oral decongestion, but there's poor control. Then the intermittent sneezing, nasal itching, and rhinorrhea via oral. So you can treat that with oral antihistamines and intranasal antihistamines. Again, no poor control. Then you have your mild symptoms that you can treat with oral antihistamines, leading to poor control. And a moderate to serious symptoms, the intranasal glucocorticoids, intranasal antihistamines, and a combination therapy. Again, poor control. The pharmacologic management of allergic rhinitis. So the combination therapy, allergy testing, reassesses for anatomic nasal obstruction, reassess for non-allergic inflammation, and immunotherapy. Again, you have poor control pretty much for all of these. So allergy testing, avoidance, immunotherapy, intranasal glucocorticoids, intranasal antihistamines. You pretty much are doing allergy testing, aggressive environmental control, and immunotherapy for a lot of these. So I'll leave this up so you can hit pause. Again, for pictures and things, it's always a good spot to hit pause so you can look at them. And I'll try to make it, make sense where you can pause. So the intranasal glucocorticoids. The basic pharmacology of the glucocorticoids is discussed in chapter 56. Considerations here is limited to the use in allergic rhinitis. Its actions and uses. Intranasal glucocorticoids are the most effective drug for the prevention and treatment of seasonal and perennial rhinitis. Because of their anti-inflammatory action, these drugs can prevent or suppress the major symptoms of allergic rhinitis, the congestion, rhinorrhea, sneezing, nasal itching, and erythema in 90% of these patients who use them properly. 7 intranasal glucocorticoids are available at this time. 3 of these are budesonide, the Rhinocort aqua, fluticasone, propionate, and triamcinolone or Nasacort are available in the United States without a required prescription. All appear equally effective. So here on table 61.2, you're looking at some of the glucocorticoid nasal sprays for allergic rhinitis. You have your first generation and second generation. You also see the trade name, the intranasal bioavailability, the dose, the patient age that may or may not use them, and the initial dosage. So it's a good spot to hit pause, make flashcards, make note cards so that you have an idea of when and how to give these medications. Adverse effects. Adverse effects of intranasal glucocorticoids are generally mild. The most common are the drying of the nasal mucosa and the burning or itching sensation. Sore throat, epistaxis, and headache may also occur. Systemic effects are possible, but are rare at recommended doses. Of greatest concern are the adrenal suppression and slowing of linear growth in children. Whether final adult height is reduced is an unknown factor at this time. Systemic effects are least likely with cyclosinide, fluticasone, and mometasone, which have a very low bioavailability if you're taking a look again at that chart. Your preparation and dosage and administration. Intranasal glucocorticoids are administered using a metered dose spray device. Benefits are greatest when dosing is done daily rather than irregularly. Full doses are given initially. After symptoms are under control, the dosage should be reduced to the lowest effective amount. For patients with seasonal allergic rhinitis, maximal effects may require a week or more to develop. However, an initial response can be seen within a few hours. For patients with perennial rhinitis, maximal response may take 2 to 3 weeks to develop. If nasal passages are blocked because of nasal congestion, they should be cleared with a topical decongestant before glucocorticoids are administered. Your antihistamines. Antihistamines were discussed in Chapter 54. The consideration here is limited to the use in allergic rhinitis. Your oral antihistamines. Oral antihistamines, again, that histamine 1 or H1 receptor antagonist, are the first line drugs for mild to moderate allergic rhinitis. For therapy of allergic rhinitis, antihistamines are most effective when taken prophylactically and less helpful when they are taken after symptoms appear. Its actions and uses, therefore, these drugs can relieve sneezing, rhinorrhea, and nasal itching. However, they do not reduce nasal congestion. Because histamine is only one of several mediators of allergic rhinitis, antihistamines are less effective than glucocorticoids. Antihistamines should be administered on a regular basis throughout the allergy season, even when symptoms are absent, to prevent an initial histamine receptor activation. Because histamine does not contribute to symptoms of infectious rhinitis, antihistamines are of no value against a common cold. Some patients take first-generation antihistamines for their drying effect. However, this may complicate treatment of colds by increasing the viscosity of secretions. So some of the adverse effects. Adverse effects are usually mild. The most common complaint is sedation, which occurs frequently with the first-generation antihistamines, such as your Benadryls, and much less often with the second-generation agents, such as your Claritin. Accordingly, second-generation agents are clearly preferred for students who need to remain alert in class and for patients who do work that require alertness. Anticholinergic effects, the drying of the nasal secretions, dry mouth, constipation, and urinary hesitancy, are common with first-generation agents and relatively rare with the second-generation agent. So, preparation, dosage, and administration. Dosages for some popular H1 antagonists are presented in Table 61.3. A more complete list is discussed in Chapter 54. And I'll see if I can link that chapter in our video somehow so that people can access that easily. Some antihistamines for allergic rhinitis. So, your oral antihistamines. Your first generation, the sedating kind, is your chlorpheniramine and diphenhydramine, so Benadryl. Your second generation is your Zyrtec, your Sizal, Allegra, Claritin, Clarinex, and the intranasal could be Astelin and Patanase. I try to stick with trade names mostly because they are a little easier to pronounce when possible. So here's a good spot to hit pause so you can make a little list of medications that are some of the antihistamines. Intranasal antihistamines. Two antihistamines, azolastine or Astelin, and I'm just going to call it the Patanase, are available for the intranasal administration. Both drugs are indicated for allergic rhinitis in adults and children older than 12. Both drugs are supplied in a metered spray device. The usual dose is 2 sprays in each nostril twice daily. With both drugs, systemic absorption can be sufficient to cause somnolence. Additionally, some patients experience nosebleeds and headaches with both Astelin and Patanase. These drugs can also cause unpleasant taste. So the prototype drugs for allergic rhinitis, cough and colds, Some of the intranasal glucocorticoids include beclomethasone, antihistamines, the azelastine or loratadine, intranasal sympathomimetics or decongestant is your phenylephrine and oxymetazoline, your opioids hydrocodone and non-opioid dextromethorphan, your intranasal cromolyn sodium. The basic pharmacology of cromolyn sodium is discussed in Chapter 60. Considerations here is limited to its use in allergic rhinitis. And I'll see if I can also link Chapter 60. Actions and use. For the treatment of allergic rhinitis, intranasal cromolyn, or nasal crom, is extremely safe but only moderately effective. Benefits are much less than those of intranasal glucocorticoids. Cromolyn reduces symptoms by suppressing release of histamine and other inflammatory mediators from mast cells. Accordingly, the drug is best suited for prophylaxis and hence should be given before symptoms start. Responses may take a week or two to develop. Patients should be informed of this delay. Adverse reactions are minimum, less than with any other drug for allergic rhinitis. Its preparation, dosage, and administration, therefore. For the treatment of allergic rhinitis, cromolyn sodium is available in a metered dose spray device that delivers 5.2 milligrams per activation. The usual dosage for adults and children over 2 years is 1 spray per nostril, 4 to 6 times a day. If nasal congestion is present, a topical decongestant should be used before cromolyn. Like the antihistamines and glucocorticoids, cromolyn should be dosed on a regular schedule throughout the allergy season. Which brings us to our decongestants, or sympathomimetics. Its actions and uses. Sympathomimetics reduce nasal congestion by activating that alpha-1 adrenergic receptor in nasal blood vessels. This causes vasoconstriction, which in turn causes the shrinkage of swollen membranes, followed by nasal drainage. With topical administration, vasoconstriction is both rapid and intense. With oral administration, responses are delayed, moderate, and prolonged. In patients with allergic rhinitis, sympathomimetics only relieve stuffiness. They do not reduce rhinorrhea, sneezing, or itching. In addition to their use as allergic rhinitis, sympathomimetics can reduce congestion associated with sinusitis and colds. Your routes and doses are shown here in the following table, 61.4. The sympathomimetics used for nasal congestion, a good spot to hit pause, especially if you're unfamiliar. So here you can have your phenylephrine, your pseudoephedrine, and nafazoline, your oxymetazoline, tetrahydroxyline, and silometazoline. So I'll see if I can hit this so that you can see all of them in one spot. So some of the adverse effects. Rebound congestion. Rebound congestion develops when topical agents are used more than a few days. With prolonged use, as the effects of each application begin to wear off, congestion becomes progressively worse. To overcome this rebound congestion, the patient must use progressively larger and more frequent doses. Once established, rebound congestion can lead to a cycle of escalating congestion and increased drug use. The cycle can be broken by abrupt decongestant withdrawal. However, this tactic can be extremely uncomfortable. A less drastic option is to discontinue the drug in one nostril at a time. An even better option is to use an intranasal glucocorticoid in both nostrils for 2 to 6 weeks, starting 1 week before discontinuing the decongestant. Development of rebound congestion can be minimized by limiting topical application to 3 to 5 days. Accordingly, topical sympathomimetics are not appropriate for individuals with chronic rhinitis. Central nervous system stimulation. Central nervous system excitation is the most common adverse effect of the oral sympathomimetics. Symptoms include restlessness, irritability, anxiety, and insomnia. These responses are uncommon with topical agents when used as recommended. The cardiovascular effects. By activating that alpha-1 adrenergic receptor on the systemic blood vessels, sympathomimetics can cause a widespread vasoconstriction. Generalized vasoconstriction is most likely with oral agents. However, if used in excess, even the topical agents can cause significant systemic vasoconstriction. For most patients, effects on the systemic vessels are inconsequential. However, for the individual with a cardiovascular disorder such as high blood pressure, coronary artery disease, cardiac arrhythmias, cerebrovascular disease, widespread vasoconstriction can be hazardous. So, it's abuse then. Your pseudoephedrine is associated with abuse. By causing CNS stimulation, this sympathomimetic can produce subjective effects similar to those of amphetamine. Also, it can be readily converted to methamphetamine, a widely used drug of abuse. To reduce the availability of pseudoephedrine for methamphetamine production, Congress passed the Combat Methamphetamine Epidemic Act of 2005, which requires that all products containing pseudoephedrine be placed behind counters. Furthermore, purchasers must present identification and sign a log. Also, individuals can purchase no more than 9 grams per month or 3.6 grams on any day. Because of these constraints, many products are being reformulated to contain phenylephrine rather than ephedrine or pseudoephedrine. Unfortunately, when taken orally, phenylephrine is not very effective. And in today's market in 2025, it's no longer an issue as the drug has been discontinued. Factors in topical administration. General considerations. Because of the risk of rebound congestion, topical sympathomimetics should be used for no more than 3 to 5 consecutive days. To avoid systemic effects, doses should not exceed those recommended by the manufacturer. The applicator should be cleansed after each use to prevent contamination. Drops. Drops should be administered with the patient in a lateral, head-low position. This causes the drops to spread slowly over the nasal mucosa, therefore promoting beneficial effects while reducing the amount that is swallowed. Because the number of drops can be precisely controlled, drops allow better control of dosage than do sprays. Accordingly, because young children are particularly susceptible to toxicity, drops are preferred for these patients. Sprays. Sprays deliver the decongestant in a fine mist. Although convenient, sprays are less effective than an equal volume of properly instilled drops. The contrast between the oral and the topical agent. Oral and topical sympathomimetics differ in several important respects. First, topical agents act faster than the oral agent and are usually more effective. Second, oral agents act longer than topical preparations. Third, systemic effects, your vasoconstriction, your CNS stimulation, occur primarily with oral agents. Topical agents usually elicit these responses only when the dosage is higher than recommended. And fourth, rebound congestion is more common with prolonged use of topical agents, but is usually rare with oral agents. So that brings us to the comparison of the phenylephrine and pseudoephedrine. Phenylephrine is one of the most widely used nasal decongestants. The drug is administered topically as a single agent and orally as a component of combination preparations. When administered topically, phenylephrine is both fast and effective. When taken orally, the drug effect is insignificant in large part because of extensive first-pass metabolism. Although it might seem logical to simply increase the dosage, this is not advisable because even though absorption is poor, phenylephrine can still cause adverse cardiovascular and CNS effects. Pseudoephedrine is available for oral administration. Compared with oral phenylephrine, pseudoephedrine is better absorbed, has a longer half-life, and is much more effective. The antihistamine, sympathomimetic, and antihistamine glucocorticoid combination. Some patients require combined therapy with a sympathomimetic or glucocorticoid in addition to antihistamine. Although antihistamines alone are a first-line treatment, they do not relieve nasal congestion and may be inadequate for some patients. For these patients, addition of a sympathomimetic or glucocorticoid may be indicated. This can be accomplished in one of two ways, by giving the drugs separately or by using a combination product. Some popular combination products are listed here in the following table, 61.5. It's a good spot again to hit pause so that you can read the combo drugs. Your ipratropium, an anticholinergic agent. The common name or trade name is Atrovent. It is an anticholinergic agent. The drug is indicated for allergic rhinitis, asthma, and the common cold. To treat allergic rhinitis, Atrovent is administered as a nasal spray. Blockade of cholinergic receptors inhibit the secretion from the serous and seromucous glands lining the nasal mucosa and thereby decreasing rhinorrhea. The drug does not decrease sneezing, nasal congestion, or a postnasal drip. At the doses used for allergic rhinitis, side effects are minimal. The most common side effects are nasal drying and irritation. Atrovent does not readily cross the membranes because it is a quaternary ammonium compound, and hence systemic effects are absent. Dosages for allergic rhinitis in patients 12 years and older range from 2 sprays of the 0.03% or 42 microgram total per nostril 2 to 3 times a day to 2 sprays of the 6%, or 0.06% or 84 micrograms total per nostril 4 times a day. The use of ipratropium for asthma is discussed in chapter 60, which is its most common use, I would say, at least in the hospital setting. Montelukast, a leukotriene antagonist. Montelukast, also known as Singulair, originally approved for asthma, is now approved for seasonal and perennial allergic rhinitis as well. Benefits derive from blocking binding of leukotrienes to their receptors. In people with allergic rhinitis, leukotrienes act primarily to cause nasal congestion by promoting the vasodilation and by increasing vascular permeability. Hence, by blocking leukotriene receptors, montelukast relieves nasal congestion, although it has little effect on sneezing or itching. When used alone or in combination with an antihistamine, montelukast is less effective than intranasal glucocorticoids. Although montelukast is generally well tolerated, it can cause rare but serious neuropsychiatric effects, including agitation, aggression, hallucinations, depression, insomnia, restlessness, and even suicidal thinking and behavior. Because of these adverse effects and because the beneficial effects are limited, it is probably best to reserve montelukast for patients who do not respond to or cannot tolerate intranasal glucocorticoids, antihistamines, or both. The administration is oral dosage, which varies with age, is the same as used for asthma. Which brings us to omalizumab, also known as Xolair, is a monoclonal antibody directed against the IgE, an immunoglobulin or antibody that plays a central role in the allergic release of inflammatory mediators from mast cells and basophils. Xolair is approved only for allergy-mediated asthma. However, several studies have demonstrated significant improvement of allergic symptoms because patients with ragweed-induced seasonal allergic rhinitis have achieved symptom relief with Xolair when other drugs have been ineffective. This drug is sometimes prescribed off-label for the management while clinical trials continue. So, that brings us to drugs for cough. Cough is a complex reflex involving the CNS, the peripheral nervous system, and the muscles of respiration. The cough reflex can be initiated by irritation of bronchial mucosa as well as by stimuli arising at sites distant from the respiratory tract. Cough is often beneficial, serving to remove foreign matter and excess secretions from the bronchial tree. The productive cough that is characteristic of chronic lung disease, including emphysema, asthma, and bronchitis, should not be suppressed. For example, not all cough, however, is useful. When cough is non-productive, creates discomfort, or deprives patients of comfort or sleep, cough suppressant medication is appropriate. The most common use of cough medicines is suppression of non-productive cough associated with the common cold and other upper respiratory infections. Your antitussives. Antitussives are drugs that suppress your cough. Some agents act within the CNS, others act peripherally. The antitussive fall into two major groups, opioid antitussives and non-opioid antitussives. Interestingly, although the major antitussive codeine, dextromethorphan, and diphenhydramine are clearly effective against chronic, non-productive cough and experimentally induced cough, there is no good evidence that these drugs can suppress cough associated with the common cold. So opioid antitussives. All of the opioid analgesics have the ability to suppress cough. The two opioids used most often for cough suppression are codeine and hydrocodone. Both drugs act in the CNS to elevate cough thresholds. Hydrocodone is somewhat more potent than codeine and carries a greater liability for abuse. The basic pharmacology of the opioid is discussed in Chapter 22. Codeine. Codeine is the most effective cough suppressant available. The drug is active orally and can decrease both the frequency and intensity of cough. Doses are low, about one-tenth those needed to relieve pain. At these doses, the risk for physical dependence is considered small. Like all opioids, codeine can suppress respiration. Accordingly, the drug should be employed with caution in patients with reduced respiratory reserve. In the event of an overdose, respiratory depression may prove to be fatal. An opioid antagonist, naloxone or Narcan, should be used to reverse toxicity. When dispensed by itself, codeine has a significant potential for abuse and therefore is classified under Schedule II of the Controlled Substance Act. However, the abuse potential of the antitussive mixtures that contain codeine is considered low. Accordingly, these mixtures are classified under Schedule V. For the treatment of cough, the adult dosage is usually 10 to 20 milligrams orally, 4 to 6 times a day. Codeine is rarely recommended for children. Bringing us to the non-opioid antitussives. Your dextromethorphan is the most effective over-the-counter non-opioid cough medicine and the most widely used of all cough medicines. Like the opioids, dextromethorphan acts in the CNS. Dextromethorphan is a derivative of the opioids. However, it does not produce typical opioid-like euphoria or physical dependence. Nonetheless, when taken in high doses, dextromethorphan can cause euphoria and is sometimes abused for this effect, which was discussed in Chapter 33. Depending on the dose, subjective effects can range from mild inebriation to a state of mind-body dissociation, much like that caused by phencyclidine or PCP. At therapeutic doses, dextromethorphan does not depress respiration. Adverse effects are mild and considered rare. Dextromethorphan is the active ingredient in more than 140 non-prescription cough medicines. The usual adult dosage is 10 to 30 milligrams every 4 to 8 hours. In the past, dextromethorphan was considered devoid of analgesic actions. However, it now appears the drug can reduce pain. The mechanism is blockade of receptors for N-methyl D-aspartate, or NMDA, in the brain and spinal cord. In contrast, opioids relieve pain primarily through the activation of the mu receptors. Although dextromethorphan has minimal analgesic effects when used alone, it can enhance analgesic effects of the opioids. For example, we can double the analgesic response to 30 milligrams of morphine by combining the morphine with 30 milligrams of dextromethorphan. Other non-opioid antitussives, therefore, your diphenhydramine is an antihistamine with the ability to suppress a cough. The mechanism is, however, still considered unclear. Like other antihistamines, diphenhydramine, also known as Benadryl, has sedative and anticholinergic properties. Cough suppression is achieved only at doses that produce prominent sedation. The usual adult dosage is about 25 milligrams every 4 hours. Benzonatate, or Tessalon pearls, is a structural analog of two local anesthetics, tetracaine and procaine. The drug suppresses cough by decreasing the sensitivity of respiratory tract stretch receptors, the components of the cough reflex pathway. Adverse effects are usually mild: sedation, dizziness, and potential constipation. Nonetheless, severe effects can occur in children and adults. In children younger than 2 years of age, accidental ingestion of just one of the two capsules has been known to be fatal. In other children and adults, overdose can cause seizures, dysrhythmias, and death. Smaller doses can cause confusion, chest numbness, visual hallucination, and a burning sensation in the eyes. If the capsules are sucked or chewed rather than swallowed, the drug can cause laryngospasms, bronchospasms, and circulatory collapse. Accordingly, benzonatate capsules should be swallowed intact. The usual adult dosage is about 100 milligrams 3 times a day. Safety and efficacy have not been established in children younger than the age of 10, so it should be considered an avoidant for children. Expectorants and mucolytics. Expectorants. An expectorant is a drug that renders cough more productive by stimulating the flow of the respiratory tract secretions. A variety of compounds, your ammonium chloride or iodide products, have been promoted for their supposed expectorant action. However, in almost all cases, efficacy is considered questionable. One agent, quifacin or mucinex, may be the exception. However, for this drug to be effective, doses higher than those normally employed may be needed. So, mucolytics. A mucolytic is a drug that reacts directly with mucus to make it more watery. This action should help make the cough more productive. Two preparations, a hypertonic saline and acetylcysteine, are employed for their mucolytic actions. Both are administered via inhalation. Unfortunately, both can trigger bronchospasms. Because of its sulfur content, acetylcysteine has the additional drawback of smelling like rotten eggs. So cold remedies, the combination preparations, basic considerations. The common cold is an upper respiratory infection of a viral origin. Between 50 to 80% of colds are caused by the human rhinovirus, which can also cause serious infection of the lower respiratory tract. Characteristic symptoms of the common cold are rhinorrhea, nasal congestion, cough, sneezing, sore throat, hoarseness, headaches, malaise, and myalgia. Fever is common in children, but rare in adults. Colds are self-limiting and usually benign. Persistence or worsening of symptoms suggest development of secondary bacterial infections. In the United States, the economic burden of the common cold is estimated at more than $60 billion a year. There's no cure for the cold, so treatment is purely symptomatic. Because colds are caused by viruses, there's no justification for the routine use of antibiotics. These agents are appropriate only if a bacterial co-infection arises. There's no evidence that vitamin C or zinc can prevent or even cure colds. There's no single drug can relieve all symptoms of a cold. The pharmaceutical industry has formulated a vast number of cold remedies that contain a mixture of ingredients. These combination cold remedies should be reserved for patients with multiple symptoms. In addition, the combination chosen should contain only those agents that are appropriate for the symptoms at hand. Patients who require relief from just a single symptom, rhinitis, cough, or headache, are best treated with a single drug preparation. Combination cold remedies frequently contain two or more of the following: a nasal decongestant, an antitussive, an analgesic, an antihistamine, and caffeine. The purpose of the first three agents is self-evident. In contrast, the roles of antihistamine and caffeine require a further explanation. Because histamine has nothing to do with the symptoms of a cold, the purpose of including an antihistamine is not to block histamine receptors. Rather, because of their anticholinergic action, antihistamines are included to suppress mucus secretion. This action can potentially worsen upper respiratory infection by thickening secretions, making them more difficult to drain. This may create an environment conducive to bacterial proliferation, which may lead to a secondary bacterial infection, such as sinusitis. Caffeine is added to offset the sedative effects of the antihistamine. Although they can be convenient, combination cold remedies do have disadvantages. As with all fixed-dose combination, there is a chance that a dosage, one capsule or one tablet, that produces therapeutic levels of one ingredient may produce levels of other ingredients that are either excessive or subtherapeutic. In addition, the combination may contain ingredients that the patient does not need. Furthermore, the U.S. Food and Drug Administration regulations, a brand name product can be reformulated and then sold under the same name. Hence, without careful reading of the label, the consumer has no assurance that the brand name product purchased contains the same amount of the same drug that were present in the previous version of that combination product. Leading us to the use in young children. Many experts believe that over-the-counter cold remedies should not be used by young children. There is no proof of efficacy or safety in pediatric patients, and there's proof of the potential for serious harm. According to the Center for Disease Control and Prevention, thousands of children have been taken to the emergency department for the management of adverse effects related to the cough or cold product. Presenting symptoms have included convulsions, tachycardia, hallucinations, and impaired consciousness. Some children have died. In early 2008, the FDA recommended that over-the-counter cold remedies no longer be given to children younger than 2 years of age, owing to the risk for potentially life-threatening events. The FDA is still reviewing the safety of these drugs in children 2 to 11. In the meantime, citing inadequate effectiveness, significant adverse effects, and common misuse. The American Academy of Pediatrics recommended restricting the use of cough and cold medicines to children older than 6 years. Manufacturers voluntarily revised the labels of the children's cold and cough preparations to indicate that they should not be used in children younger than 4. In addition, for products that contain an antihistamine, manufacturers added a warning against the use of these drugs to sedate children. After these interventions, emergency visits related to cold and cough medications decreased significantly for children younger than 4. To minimize harm to pediatric patients, parents should do the following. 1. Avoid over-the-counter cold remedies in children younger than 4 to 6 years. 2. Only use products labeled for pediatric use. 3. Consult a healthcare professional before giving these drugs to children. 4. Read all products' safety information before dosing. 5. The use of measuring device provided with the product. 6. Discontinue the medication and seek professional care if the child's condition worsens or is failing to improve. 6. Avoid the use of antihistamine-containing products to sedate children. That completes chapter 61. I thank you all for listening and watching, and I'll see you at the next chapter. Till then, thank you and take care.